I will show now the fluoroscopy of the case. First, we can appreciate the CRT D with dual coil on the RV lead and the CS LV lead inserted in the posterolateral branch of the coronary sinus. First of all, we introduced the decapolar catheter in distal CS at junction between the CS proper and the anterior interventricular vein. Then this is the RAO view of the case. Where the CS inside the CS, and we started to introduce the ablation catheter here. The ablation catheter is at the LV summit opposing the CS distal CS catheter. This is our RAO view. This is the LA view of the ablation catheter at the LV summit opposing the distal CS catheter, where we found an interesting signals, and we delivered ablation at this site. This is another position of the ablation catheter, which is introduced via the right femoral artery and via a long sheath for better stability. This is the junction between the right coronary cusp and the left coronary cusp. This is the introduction of the ablation catheter from a right femoral vein into the CS for further mapping and to appreciate any earlier signal than we got from the endocardial side. This is considered an epicardial mapping of the target PVC, which is the activation map. Here we can appreciate the presence of the ablation catheter in the distal CS. Here the long sheath in the aorta without an ablation catheter. We delivered in the last area also. We did more than ablation here. Then we got back into the left coronary cusp for further mapping endocardially. This is RAO view. This is the LA view again in the LV summit.
This is the original PVCs before ablation. As we can see, it is inferior axis being lead 2-3 AVF positive. Also, it's a transition at V3 with negative in lead 1. We suspect a left-sided origin definitely, and being dilated cardiomyopathy, an area of LV summit or basal anterior wall is our target, and definitely these PVCs is of epicardial origin, as the MDI is more than 0.6. We first enter a decapolar catheter inside the coronary sinus and deeply engage inside the coronary sinus cardiac vein, and we got a very nice potential preceding the QRS complex by about 25 to 30 millisecond pre-QRS complex from the great cardiac vein. And these emphasize that the origin of such PVCs is from the LV summit and the basal of anterior wall of LV. And again, the MDI of such PVCs is from the starting of the PVCs till the peak of the QRS complex about 120, divided on the QRS duration, which is about 200, so it is 1.6. And this also emphasizes that epicardial origin of such PVCs is the cause. So our plan to enter into the endocardium from the LV, opposing the LV summit and the opposing البيز of anterior wall together the left coronary cusp. All such area we will map and we will look for both systolic potential, late potential, lava, and we will measure and we will do activation map during the BVCs. This is the left coronary cusp. The left coronary cusp, we clearly see that a little minute signal is preceding even the coronary sinus and preceding the QRS complex by 36. So this area is highlighted, and we will ablate at such area after finishing our activation map and voltage map. This is from left coronary cusp. During such a site, we could see clearly that there is a very late potential, very late systolic potential after the end of the QRS complex. Again, here is the endocardial site of LV summit, and during sinus you could see clearly that a post systolic potential or late potential, fractionated potential is present, and this is a very good site, a target for ablation. During BVCs at such a point, at such site of this late potential from the endocardial side, we could see during BVCs a double potential is an early and the pre-systolic, and one is late. Ablation of such a spot make the BVCs goes for about 2 or 3 minutes, as we can see. No BVCs was here in our first trial at such a site. دي لما كونا أول مرة وكانت راحت خالص. We can see that no BVCs in the first 2 to 3 minutes after ablation. Recurrence of BVCs had occurred, and we decided to do more extensive ablation in the basal anterior area and eliminate all diastolic potential or late systolic potential. This is a late potential. We could get it from the endocardial side of LEV summit. Clear was it is a very late. This is the QRS complex, and definitely we are late. But during BVCs, it has this fractionated component divided into 2 components. One which is early and second is late, and also this is a very good site for ablation. Then our strategy to ablate the basal anterior wall corresponding to the endocardial side of LV summit, ablation from the left coronary cusp, and again ablation inside the great cardiac vein. So these are the 3 sites we do an ablation from it. After ablation from such point, we could definitely eliminate the BVCs totally with no recurrence of BVCs. Okay, thank you.
Preparation of the case, the programmer, and interrogation of the device was very important, especially we have telemetry, we can deal with it. We were turning off all, the therapy unless he gets VF, and he already got one when we started. This is his interrogation screen, and we were turning this off and this off so that he does not get shocks from interference in the room or the. We have to. I want to show you the episodes. This is one of the VF episodes. This is terminated by shock here, but I want to show you how it started. You can see started by PVC and firing. This is why I said we have to ablate the PVC coming from that scar. As you can see, VF was detected. Pacing during charging. Here, this is the green ones. Here pacing while charging, F detection after pacing, here pacing while charging, and then VF detection again, and this is shock and termination. This is one. Another one also, you can see how it started here. Again, PVCs and here is the firing. He had a lot of PVCs, as you can see, a lot of PVCs firing, and the morphology of which I will show in the ECG was coming from this summit. This is the anticardiac pacing during charging not effective, and VF going, as you can see, VF, shock and termination. So this was the plan put because of this high risk patient. Also we had these patches for this shock with the connected to this shock here through a module here. This also helps you in case the disc shock of the device fails, then you have the external disc shock. This all the prerequisite preparation so that patient is safe. Thank you very much.